Hello, all. My name is Zohir Chaudhary, and it's great to be here. We will discuss today the historical motivation that led to revising the 1969 International Health Regulation, or the IHR 1969, and eventual adoption of IHR 2005. Okay, let's get started. The first International Sanitary Regulation, or ISR, were adopted in Paris, France, back in 1851, which can be traced as the beginnings of global health security regulations as a response to threat from cholera and other infectious diseases from outside Europe. 3 years after the creation of the World Health Organization, or the WHO, in 1951, the WHO issued its first infectious disease prevention regulations, known as the International Sanitary Regulation, or ISR 1951. The ISR 1951 provided a single set of rules to help member states control the spread of 6 quarantinable diseases. Then, the 22nd World Health Assembly in 1969 adopted, revised, and consolidated the International Sanitary Regulations, or the ISR, which were renamed as the International Health Regulations, or IHR. And since this was adopted in 1969, it carried that year as its designation as IHR 1969. So since the adoption of IHR 1969, significant progress was made. In the case of smallpox, global cases declined significantly due to vaccination campaigns worldwide. By 1952 and 1953, smallpox was gone from North America and Europe, but remained a threat outside the Western countries, in particular from Asia, Africa, and South America. By the early 1970s, after ISR 1969 adoption, and mid 1970s and late 1970s, South America, Asia, as well as Africa followed suit in eradicating smallpox as well. On May 8, 1980, the last smallpox case was eliminated on the planet. On this day, the World Health Assembly announced the world free of smallpox. That was a great victory for public health. Thus, from 1969 to 1981, significant progress was made with both cholera and smallpox. Thus, the 26th World Health Assembly in 1973 amended the IHR 1969 in relation to provisions on cholera. In view of global eradication of smallpox, the 34th World Health Assembly amended IHR in 1981 to exclude smallpox in the list of notifiable diseases. Thus, by the mid-1980s, only 3 diseases were reportable under IHR 1969. Remember that when IHR 69 was first adopted by the World Health Assembly in 1969, 6 diseases were reportable, and they were cholera, plague, yellow fever, relapsing fever, smallpox, and typhoid fever. But by mid-1980s, the 3 were dropped: relapsing fever, smallpox because of eradication, and typhoid fever. So only 3 were reportable by mid-1980s. So they were cholera, plague, and yellow fever. However, emerging infectious diseases, or EID, and re-emerging infectious diseases, REID, were not gone. Specific infectious pathogens such as influenza viruses continuously emerge and re-emerge. Infectious pathogens have always affected humans through the ages, and we know from the various outbreaks and pandemics over humans' early history. Since IHR 1969 and until the early 2000s, at least 33 emerging infectious diseases were detected. A significant uptick was detected between 1980s and 1990s, leading to the early 2000s. That was and that was caused serious concerns. But the international regulations had no mechanism to deal with all of these emerging and re-emerging infectious diseases, since the reporting focused on merely three diseases, such as cholera, plague, and yellow fever. And in this map, we can see in here from 1996 to 2007 has been reported. You can see a lot of emerging and re-emerging diseases essentially spreading all over the world. And many of them you can probably recognize as well. So the world has significantly changed. So at the same time, the world changed significantly from 1969 to early 2000, and we can define this change as the global population continues to grow exponentially. The demographic makeup of the population's age also shifted more towards an aging population in many parts of the globe. And also people are traveling more frequently all around the globe. There was increased trade and other things going on at the same time. These unique conditions of the 21st century amplified the invasive and disruptive power of epidemics and other public health emergencies. The dynamics of diseases spread in the world have changed greatly in the last few decades as well. We are all living in a global village where diseases can travel at the speed of jetliners on the wings of international travel and trade, and can jump from one continent to another in a matter of hours. This has made all nations vulnerable, not just to invasion of their territories by pathogen, but also by the economic, political, and social shocks of public health events elsewhere. These pathogens and diseases have the power to disrupt the entire global system in ways that cannot be controlled by one nation acting alone. So on top of this, we face threats of biological, chemical, radiological, or nuclear in origin threats that affected human health as well. So the nuclear disaster in Chernobyl, for example, in Ukraine in 1986, was a wake-up call. As a result of this disaster, more than 5 million people were exposed to radiation. 600,000 people's property were contaminated, and among this contaminated property, 1,000 people received the highest level of radiation. By 2002, more than 4,000 thyroid cancer cases were associated with this disaster. Also, the risk from smaller, more powerful, and more affordable biotechnologies was also increasing. Deliberate release of infection agents such as anthrax spores, an increased risk of accidental release of infectious agents used in biosafety laboratory around the world, such as SARS, was no longer a remote threat. So global security was really at stake by this time. Avian influenza, also known as bird flu, is an infection caused by avian influenza viruses. This has emerged as the primary public health concern of the 21st century. The first outbreak of human infection by avian influenza virus, or H5N1, was observed in 1997 in Hong Kong. Since then, a large number of outbreaks have been reported in different parts of the world. In this map, we can see human cases of H5N1, known as bird flu, and also the spread or the spillover of avian influenza in various species, including humans, had led to a pandemic threat all over the globe. So the current spread of avian influenza H5N1 in domestic poultry flocks and wild birds across the world, as well as the demonstrated ability of this virus to cross species barrier and infect humans had led to a high level of concern that a pandemic may develop. For a pandemic to arise, three prerequisites have to be identified. A new virus subtype to which the population has little or no immunity must emerge. Two, the new virus must be able to replicate in humans and cause serious illness. Three, the new virus must be efficiently transmitted from one human to another. Unless most pandemics which emerge randomly, H5N1 has been recognized as a likely pandemic candidate for almost 10 years. By March 2003, outbreak of severe acute respiratory syndrome or SARS shocked the world as it spread swiftly from continent to continent, resulting in more than 8,000 infections, with approximately 10% mortality and a devastating effect on local and regional economies. Three laboratories, one in Hong Kong, another one in Germany, and the third one, the Center for Disease Control Prevention of the CDC in Atlanta, Georgia, United States, nearly simultaneously isolated an apparently new coronavirus as the case of SARS. The potential for global spread of SARS was quickly recognized by the World Health Organization, WHO. The Global Outbreak Alert and Response Network was activated to help identify and deploy volunteers from around the world to assist the most severely affected nations. In the absence of international health regulations, WHO rapidly issued several recommendations to help nations control outbreaks and prevent spread. SARS was the first disease of the 21st century to expose the world's vulnerabilities. SARS taught us how quickly a new disease can spread along routes of international air travel. Shared vulnerabilities imply shared responsibilities and create a need for strong collective action to protect lives and livelihoods from disease spread. In this map, this is actually taken from a publication by Churi et al., published in 2019. It shows that Hong Kong was among the first cities affected by SARS, and its healthcare community suffered greatly from the disease. Taiwan, Hong Kong, Singapore, and Australia, as a result, implemented new entry health screening through their airports and other entry ports in their nations. And Canada, on the other hand, implemented both entry and exit health screening to respond to this threat. Millions of cases were detected as this entry and exit point at this entry and exit points, as you can see in the map and reflected in these boxes. Some lessons from their experiences included recognition of the value of real-time information in a rapidly progressing epidemic, with a large number of cases and the need for frequent patient updates. Challenges of national efforts to maintain entry and exit health screening among international travelers, and implementation of home quarantine as an effective tool to interrupt SARS transmission. And as we'll quickly see, some of these learned experiences have been adopted in the health regulations that we are about to introduce. So SARS finally spurred the energy of the world states to strongly take action and strengthen global defenses to health threats without boundaries. To address these public health risks, the world's country, through WHO, initiated an intensive process to revise the IHR and eventually adopted a revised IHR in May 2005. In today's world, diseases travel fast, and no single world can protect itself no single country can protect itself on its own. So acknowledging this risk, all 193 member of WHO at that time signed this IHR in 2005. After a decade of discussion from 1995 to 2005, and pushed by the emergence of SARS, in 2005, the World Health Assembly adopted this revised IHR. So, in their words, this adoption was to prevent, protect against, control, and provide a public health response to the international spread of disease in ways that are commensurate with and restricted to public health risks, and which avoid unnecessary interference with international traffic and trade. Thus, the revised IHR was a collective process that was initiated in 1995. It identified the gaps in the 1969 IHR and transformed it into an effective regulatory tool for WHO member states to strengthen global disease surveillance and to proactively and be proactive in dealing with international outbreaks. The revision approach is based on three specific principles. One, ensuring that all public health risks, mainly of infectious origin, that are of urgent international importance are reported under the regulations. Two, avoiding stigmatization and unnecessary negative impact on international travel and trade, and invalid reporting from sources other than official member states. And this reporting, this unofficial reporting, can have serious economic consequences for countries. Number three, ensuring that the system is sensitive enough to detect new or re-emerging public health events. So the IHR represents a major step forward in international public health security. They provide an agreed framework for the collective international management of epidemics and other public health emergencies while minimizing disruption to travel, trade, and economies. So these regulations became legally binding and came into force 15 June 2007, and it was legally binding by all of the WHO member that signed. And there were some extension to some of the countries. I believe India had some reservation, US also had some reservation, and Turkey had some reservations. And once it was incorporated, they also signed the in here. And Dr. Margaret Chan, WHO then director, she said that it will now be up to the world to translate this new code of regulations into reality of greater international public health security.